Thanks again for the opportunity. Great turnout today, and especially as I mentioned with the weather. Sandy may have alluded there, I'm from Dublin, Ireland, so hopefully everyone understands me. We tend to mumble as Irish people, but I will try and keep it nice and eloquent. I'm over here working for a year. It's been a fantastic opportunity to work with some what I would regard as world leaders in the field in this area. So I did all my training back home in Ireland, and I'm actually going back to an attending position in about 5 weeks' time. So this is timed nicely to have this opportunity. So myself and Dr. Chugtai, I suppose what we wanted to talk about was female pelvic health. And it's a very, very broad topic with lots, I suppose there's lots of discussion around it. Dr. Chugtai, when we were preparing this talk, he's a big man for trying to start a quiz, and just, I suppose, to get a baseline. I realise some people some may have a medical background or nursing background, others may be just curious or interested, but I suppose just to gauge what people feel about female pelvic health and what they know. I mean, would anyone think that a pelvic floor disorder is a common? I mean, show of hands, would anyone think of what a 1 in 3 or a 1 in 5 might be? Say 1 in 3?
1 in 5.
1 in 5, okay. We'll get there. What about bladder control problems? Is this something that only happens after menopause, or can anyone get this? Or what do you think? False. There you go. Bright bunch today. What about in the US, the number of adults with bowel incontinence? What do you think? C. You will find out shortly over the course. And then we talk about the risk for pelvic organ prolapse. So, is it just something, is there any factors that can help? Is it age? Is it just giving birth? Smoking, your lifestyle? Or do you think all of them could have a combination? To be informed shortly. So, when we talk about pelvic floor disorders, what we're talking about really is 3 things, and that's mainly bladder control, bowel control, and pelvic organ prolapse. And over the course of the next few minutes, we're going to get an opportunity just to discuss all of these things individually. And I suppose ultimately what we want to know is how can we help with this. So we're going to discuss about treatments, and ranging from what you can do to what we can do. So I mean, the fact is actually 1 in 3 women will have a pelvic floor disorder over the course of their lifetime. So including that bowel, the bladder, the prolapse issue. So this is a very, very common problem. So when people talk about the pelvic floor, it's kind of nice to give a diagram approach to see what exactly it is. So if you went through the meat slicer and we had a look down the middle, this is your bladder. It sits in front, and this expands as it fills with urine. Your uterus sits behind there, and then your rectum there. And there's almost like a hammock effect of musculature, and it's muscles that meet at different levels and different types of muscles, and they form what we know as the pelvic floor. So, as we said, there's different muscles, ligaments, connective tissue, and it is actually the lowest part of the pelvis. So it supports all the internal organs, so it's a pretty important structure. And maintaining its strength is really what helps with quality of life and helps prevent these problems that can occur. So people can get problems with their bladder, they can get bowel, and when you get weakened support, and that puts added stress on these structures around. So there's a variety of different symptoms that people complain of, and some people here may twig that they might feel a pelvic pressure, a bulge in their vagina when they strain. They might notice some urine leakage, an overactive bladder. You may have seen billboards around down the subway, and that really means that you've got to go to the bathroom quick. Some people say they strain and have difficulty emptying their bladder, that they feel they go to the toilet and then when they're finished, they think, well, I didn't pass much and I feel like we've got to go again. Other people may have a problem having a bowel movement, and other people may notice that they have leakage of stool or gas. But what we often see is that people have, a multitude of these problems that can exist. So in answer to the question of does it just affect women over the age of menopause, it actually can be quite common in younger people, and even 1 in 4 women aged 20 to 39 have been reported to have a pelvic floor disorder. The risk increases with age, but also pregnancy and childbirth. Coming from Ireland, where I've worked in clinics, and you regularly see people who've had 9, 10, 12 babies, and you wonder how this affects, but everyone is slightly different. And sometimes the more children you have, particularly if you have given birth to vaginally, that the structures can get weakened over time. So the other things, the not so good things that we shouldn't be doing, I suppose eating too much, causing obesity, not exercising, these all weaken muscles, and this can all interact, and also smoking. This has several effects. It can weaken the muscles, it can cause increased coughing, it can cause problems to the nerves, so smoking can also have a considerable effect. And then there's other things that we have absolutely no control over. These may be if you've had a stroke, if you have problem urinating or having a bowel movement due to another disorder, so it's a neurological disorder, one of this, or something like that. Or you may have had an injury to your pelvis, you may have been in a car accident, you may have had a major operation in the past in your pelvis, and these can all cause these problems. So we mentioned before about the 3 types of pelvic floor disorders, and we're going to go through each of these individually, and we will have time at the end to just discuss and go through if anyone has any questions. So the big 3 that we deal with, well, 2 in particular that we see are the bladder control problems and then the prolapse. The bowel control problems are also very common, and colorectal surgeons will often be referred to this. So bladder control, you're not alone if you have problems with this. This is an incredibly common problem. So they estimate, when we do surveys and research through databases, about 18 million women in the United States that have issues with urinary incontinence. And something we see sometimes is that people actually don't go to their doctor. They think this is part of normal aging. I don't need to talk to anyone. My friend has it. I don't think I'm as bad as her, so I won't go seeking help. But we do find that up to a quarter of people wait longer than 5 years before they do go and seek help. Now, 41% will go and see within 1 year, but I suppose everyone's different. And some people prefer not to bother people, or they just think that they're happy enough the way they are. So we've got to talk briefly about how the bladder works. So we're going to just focus now on bladder issues. So the bladder is, as we said there, just that storage device there, and it's kind of an amazing organ. So your kidneys, which are higher up, make your urine, comes down the little tubes, and then they enter the bladder. Your bladder fills up, and your brain then tells you to go to the toilet. So the bladder capacity can vary approximately about 400, 500 mils, so just under a pint. But some people find that they go to the toilet much quicker than that. So the muscles around the bladder and contract it, but then the muscles that are at the base of the bladder help it stop leaking. We do have a conscience mechanism that we ourselves just don't leak in man, but we also have what's called an external sphincter, which is when we go to the toilet, why we can go to the toilet, that we can open this and goes, but some people have problems controlling that, or the muscle is too weak. So when we need to go to the toilet, the nerves that come from our brain, and it's a very, very complicated process, cause the bladder to contract, and then urine gets expelled. But there's an awful lot going on, and really it starts up in the brain, but there's multiple sites all along the spinal cord, along our back, which control this reflex. So, do you have symptoms of bladder control issues? So, I mean, some of the things that some people might complain of is that they may get loss of urine, so they get incontinence. We mentioned before about difficulty emptying, so they go to the toilet, they go to sit down, and nothing really comes, and if it does, it's a very, very weak stream. The other problem that people sometimes notice is that they get this strong urge to go. So you start, once you drink something, that you get this urge to go to the toilet that you can't really defer it, and that's kind of would be overactive bladder. And sometimes the overactive bladder, that can be so bad that you get a contraction or a wave that you actually start leaking. So when we talked about the different types of stress incontinence, I'll try and keep this as simple as I can, but even for us it can get confusing because there's a huge overlap between the different problems, and not everyone fits one picture, and in particular a lot of people may have several of these problems. So when we talk about stress incontinence, it's not due to high school exams, it's not due to, you've got a busy day or a function coming up. It's what we call pressure. So really when you cough or sneeze or lift or anything that you might leak urine. And this varies from a few drops to people that worry about soaking themselves, so that they might wear a pad. The other type is what we call urge incontinence or overactive bladder. So this is really when you gotta go. You can't really defer the urge to pee. Excuse me. And sometimes the urge can get so bad you start leaking. Apart from the urge to go, some people find that they go to the toilet a lot, so they may need to go frequently. They may have gone an hour ago and they have to go again, or maybe every even half hour. So sometimes we refer to this as almost the key in the door sign. Not too many people drive here in New York, but at home people would often refer that as soon as they get home and they see their house, they get this urge to go to the toilet and they got to get in there quickly. Alright? So now, to complicate things, we're not simple people, doctors, so you can get both of these, and you can get a mixed bag of everything here. And really the important thing is, what is the predominant symptom? So what do you complain most often? Is it the leaking with coughing or sneezing, or is it going to the toilet all the time? And that's something as doctors, when we talk to you, that we try and just figure that out and see what we can treat as a predominant symptom. So what can we do about bladder control? Well, it kind of has to be tailored until what your problem is, as we say. And if you go online, there are multiple things that you can look at, and help and aids and guides. But some things, the simple things are simple. And losing weight is one thing if you're carrying too much weight. Limiting alcohol and caffeine. As an Irish person, we have a particular fondness for tea. I think we're the highest tea drinkers in the world per capita. And I've had patients come and say they drink 16, 18, 19 cups of tea a day. That's pretty much all they drink. So if you drink caffeine, you're going to go. So you reduce that thing. And I know here it's coffee, but tea's for me. But you can also then work on your pelvic muscles. So people go to the gym here. You can send your pelvic muscles to the gym. And you can do that yourself. And we'll talk about some of those things that we can do. And that all helps strengthen up your pelvic floor. So the other thing that you might get is a bladder diary. So when you go and see your doctor, he might give you some homework, and that involves you doing out a diary. And what that does over the space of 3 days, it gives us a real accurate picture of what's happening to you. We get you to fill in how often you go to the toilet, how much you pass, and when you leak. And also we get you to make a record of what you drink, and we get a great picture then of what really is the problem. If you're passing small amounts, then we can say if you're passing 100 mils, 150 mils, or some patients, when they look back and you see that they're going to the toilet 3 or 4 times after they drink their extra large Starbucks coffee. I mean, that's probably the reason that they're having that. So it's a great tool for us to use. So what can we do about treatments for stress incontinence? Well, not everything involves surgery, and once you've tried doing the conservative things, pessaries are often used, and these come in a variety of forms, and essentially what they are a small plastic donut ring that's inserted into the vagina. And really that does, it's a prop or a splinter, almost like a scaffold. It helps prop up the pelvic floor, it gives it a bit of added support, and that can help with incontinence. And we do know that does help. It has to be tailored your size, and your gynecologist or urologist will be able to tailor the size that most suits for you. The other thing we can do is what's called biofeedback, and I suppose that's another fancy term for pelvic floor muscles. And ultimately what that means is you will be brought in, a nurse will show you how to contract your bladder floor. You look at a screen and you get to see how your muscles move and contract, and by doing that you help to learn how to strengthen your muscles and feel the response that you're getting. You can also retrain your bladder. We tell some people, when they ask, I get the urge to go to the toilet, and we say, well, what happens if you don't go? And they go, oh, it goes away. And what we try and get them is to either do a pelvic floor contraction, let that urge disappear, and then just see what happens. Sometimes they can last for a bit longer. It's kind of in our instant, oh, I need to go to the toilet, I better go now. But sometimes you can defer it if you don't think you're going to leak. So the other types of surgery that we do are surgical treatments, and really for stress incontinence, these are some of the best results. Some patients we recommend what are called bulking agents, and they may be for patients who may be suitable to go for a big operation, or want a limited approach. And really that can be done in the office, or a very quick operation or local anaesthetic. And we inject into the urethra, which comes out of the bladder, some it's a substance which kind of bulks up or narrows the space to try and make the exit from the bladder kind of sturdier and the fluid doesn't leak. The other thing that we can do is we can put in a sling. So I'm not sure if any of you have heard of that before, but what we do is we either use a piece of mesh or your own tissue from your stomach, and we almost do like a hammock effect to kind of lift up and prop up this urethra or this tube coming out of the bladder, so there's more support. So the other type of incontinence is your urge incontinence and this overactive bladder. And really one of the key things for this is your lifestyle changes. So this is trying to retrain your bladder to learn to control to when you go. So voiding by the clock rather than by the need. So trying to defer this need to go to the toilet if you can at later times. Also, cutting down on your caffeinated drinks, trying to help your bladder itself by reducing the amount of urine. And again, strengthen your pelvic floor. It's not just stress incontinence. We do know that if you strengthen your pelvic floor, it just helps the overall system down below. So biofeedback, which we mentioned for the stress incontinence, is also useful. But also one things you may have again seen adverts everywhere are medicines for overactive bladder. So there's a lot of medicines in the market. They're hugely prescribed. They vary in side effects. There's new ones coming out all the time. One of the main side effects might be dry mouth and sometimes constipation, but that's kind of the minority of patients. But there's newer tablets coming out all the time, but they can be quite effective. But we really recommend that you try the lifestyle modification, and then for second line treatment we reserve the medications. You can also do some operations for overactive bladder. So you can get, I'm sure you've heard it, I think the Met Gala was on last night, wasn't it? There was a lot of Botox on view. We can put Botox in your bladder and it's pretty effective. And it lasts about 6 months, and what that does is it slows down the bladder muscles and means it doesn't contract as much. And in general, people get a really good response for that. Now, in rare cases, less than 10% of the patient, it works too well and you don't empty your bladder properly. But in general, the vast majority of people, when they get to that stage, they notice an improvement in their life. And the other thing that we've started doing a lot of recently is a pacemaker for the bladder. So this is called an interesting device. I think I put in 2 of them yesterday. But these are for patients, again, who may have failed all these different treatments and really they want something done. And what we do is we implant a small lead near the back, and we don't fully know the exact mechanism, but we know by inducing an electrical current around the nerves, the bladder, it stabilizes it. And we've had some pretty good success, but any operation is an operation, so we really try and work our way through this treatment pattern until we get to the last stage. And some people need a little bit of everything. Even if they have an interstim, you're still told to refrain from drinking 10 cups of coffee, or we might have to give them a top up with medicine. So again, it can be a mixed bag, but really that's our real algorithm of treatments that we go through. I'll briefly go through some bowel control issues. Now, I'm not a colorectal surgeon, but we do deal with this on occasion, but there are experts in this field as well. But again, it's a very, very common issue again. So nearly 18 million US adults, similar to female incontinence. 1 in 12 complain of fecal incontinence. And this sometimes can be the most embarrassing problem that people complain of. Whatever about people really sometimes worry about fecal incontinence, and it's one of, it can be people really wait, and they might avoid going to a family occasion or something, that they don't go and seek help. So, it's something you really should just discuss with your primary care doctor. And there's treatments that you can do, and some of these are just over the counter from Dwayne Reed, just regulating your bowel that we can help with. It may be due to a medical problem. There's certain conditions like your thyroid or whatever that can all affect your bowel. So I mean, getting checked out is important, but there are treatments. So I mean, briefly, the way the bowel works is that when your rectum is full at the end, so it's working its way through your intestines, it stretches to the point that it's full, and then your brain tells you to go to the toilet. And sometimes people, again, with their pelvic floor, which surrounds, can have some weaknesses, and this sphincter, or this muscle that stops the leaking, can cause incontinence. So, you know, it's an important issue to address, because, you know, some people, sometimes they get accidental loss of gas or bowel movements. A lot of people we see complain of chronic constipation. You know, it's recommended over 4 million people, but even looking at that figure, I'd say that's underreported. Some people may only pass a bowel motion 3 times a week. They may notice that their stool is dry, hard, difficult to get out. They strain a lot. It's sore, and they can get some bloating as well. And then you can get the other end, where you almost can sometimes get diarrhea or loose watery stools, and that might be related to overflow, where you've got so much stool that, you know, that it's seeping around the edges. So, I mean, these people, patients suffering from this, can, you know, end up going to the toilet 2 or 3 times a day. And however, though, no, if you're getting an episode of diarrhea that comes on very suddenly, is lasting for days, you know, it's important to, you know, you may have picked up a bug or something, that you do need to see someone. So it's, again, it's emphasise that, you know, do seek medical help. You know, there are simple things that can address this. You know, and some of these things are just to make your stools firmer. So by making the stool kind of a better consistency, you can help the passage of normal bowel motions, and all of this helps regulate you. You can eat, you know, grains, fruits, veg, high fiber cereals. It all works. Prunes, everything helps, and sometimes even taking fiber to bulk up your stool can be very helpful. So, I mean, sometimes people notice that they have spicy foods or fatty foods or a lot of caffeine. They can, you know, contain very loose bowel motions. But then the other people who eat a lot of rice, pasta, white bread, a lot of carbs, can notice that you get quite constipated. So a lot of the treatments for bowel issues, you know, over-the-counter stuff, laxatives, anti-diarrheal medications to help reduce that. You can go for physical therapy, again, like the pelvic floor for your bladder, that you can strengthen these muscles, and also the biofeedback that we do can help. And there is surgeries as well. You can, goal of these surgeries is to improve your bowel emptying, bowel control, and help with bowel emptying at the appropriate times. So what types of surgeries? It varies. We can get bulking agents into the rectum, again, just into the sphincter, to try and improve the tone and the, you know, help it oppose more. The pacemaker that I talked about for bladder controls is starting to be used for fecal incontinence, and that seems to have really good effect, particularly from a quality of life point of view. You know, if someone is less fecally incontinent and you can help control that, it makes an amazing difference. You can go for kind of a bigger surgery where you get an operation to repair the muscle that stops the leaking, or even you can get a sling, like a sling that we do for the bladder. You know, there's emerging data where you can put a sling around the anus to help that. So also, it's really trying to work out a treatment algorithm which works for you, and, you know, it all depends on the patient's story, and that's one of the important things when you talk to your doctor, they can figure out. So the last one, nearly there. I hope you're all not too bored, or everyone can understand my Irish accent, but the prolapse is the last thing that I wanted to talk about. And this is one of the commoner things that we deal with, we see a lot of, and it's about, I think about 30 to 50% of all women at one stage will have prolapse. Now, that's kind of a startling figure, but the vast majority of people won't have a problem. It's figured probably about 3 to 6% of people actually are really symptomatic with this, but that's still quite a high number when you think of, you know, I suppose, the number of women in the country. So it gets more commoner as you get older, and I think about 11% of women by the time they reach 80 will have had an operation for pelvic organ prolapse. And we'll go through exactly what I mean by pelvic organ prolapse in a second. It's far commoner in postmenopausal women, and giving birth one or more times is a risk factor for developing pelvic organ prolapse. Also, like with the urinary issues, lifestyle, so being overweight can play, and also smoking. It's not just bad for your lungs, it's bad for the pelvic floor. So chronic coughing, weaken the muscles, the nicotine, that can all affect.
Stop it.
It'll stop.
Okay.
So chronic lung disease is the other issue. These may not be, smoking induced. This may be whether you've got emphysema, another problem, but having a chronic cough all the time is permanently putting strain on the pelvic floor, and this can all cause pelvic organ prolapse. So what am I talking about? Well, we refer to it as POP or POP, and it's like what we're saying about these pelvic muscles. Again, it all comes back to these few muscles that all intertwine, and the uterus over time starts to bulge out, and it's not just the uterus. You can notice that the bladder, we get what's called a cystocele. So sometimes when you examine the patient, they're in their vagina, the bladder is starting to fall into the vagina. We get another issue where the uterus itself starts to fall down and starts to bulge out of the vagina. And this isn't just, if you've had a hysterectomy, we notice as well that the top of the vault of the vagina, as we call, can also prolapse out. And the other type of one, is the rectocele, which actually isn't in that picture. So you see how severe your uterine prolapse can get. But the other type is what we call a rectocele, where the rectum actually bulges in to the vagina. And one symptom that people may complain of is what we call splinting, is that when they need to pass a bowel motion, they actually have to put their two fingers into the vagina and help push out the bowel motion. So that can be a symptom of a rectocele. But the general problem is a bulge or a feeling of discomfort, or you may not necessarily see something popping out, but it can be just related to this chronic sensation of a dragging or a discomfort down below. So as we mentioned there, so pressure, heaviness, bulging. Aside from bulging, because everything is in such close proximity, you can start having urinary issues. And sometimes a prolapse can be so bad that it actually kinks the exit of the bladder. So you don't get incontinence, you actually get the other, that you have to strain to go, because the tube that you pee through is actually bent or kinked, because the prolapse is dragging everything down. So you might notice a weak stream. The other issue mentioned the chronic bowel problem, so having to push to get your bowel motions out because this fullness or defect that's bulging into the vagina. And then the last one is pelvic pain. So some patients complain of pain all the time or just during sexual activity. So there's a variety of problems that could indicate pelvic organ prolapse. So low back pain is another one that may be associated, but often with the dragging sensation. So what can we do? So it really depends on your symptoms. Not everyone with a prolapse. Some patients have a prolapse that to us looks quite bad, but they tell you, I'm fine, I'm fine, I don't need anything done. We don't need to do anything. This is, pardon the pun, is not going to kill you. And it is something that is a quality of life issue in treatment, but particularly if it's causing urinary or bowel problems, if we can help treat that, and that will improve ultimately how you feel and how you get on with your daily activities. So we can do our conservative approach. We can do watch and wait, see what happens over time, see if it gets worse. We can try and do some dietary changes, try and help lose weight. Pelvic floor exercises, a lot of it comes to that. And it's actually trained physios in these areas, and they're excellent. They're the experts who deal with this every day and are really good at giving exercises. We can use the pessary that we mentioned before, but for prolapse is really where it has one of its main uses. And some patients do find it uncomfortable, but the vast majority of patients do notice that it will help them. And again, it can be inserted and changed every few weeks by your doctor. And some patients, we at the clinic will do it by themselves quite happily, change it, and they get a great outcome. Finally, what we can do is surgery, but again, every woman's condition is different. It really depends on the type of prolapse and what surgery we can offer you. There's a variety of approaches. Sometimes we can do everything through the vagina. In the past, there's a lot of controversial reasons, but people have put mesh in to support in the bladder. Other people need a bigger operation where we need to go in through the actual abdomen or in through the tummy and try and pull up the prolapse and stitch it to the back of the bone, and we can actually do that robotically now with the robot. So we're getting great outcomes with that. So it really is, it depends on what symptoms you're having, ultimately what you feel and what you think will help you change. Some patients, there's operations we can do to push back the vagina, close off the prolapse, but it means you can't be sexually active. So there's a range of different operations that we can do. And ultimately it does extend on the experience of your surgeon. So it is worthwhile going to someone who is trained in this procedure, has a specialist interest and expertise in the area, and there's a wealth of people around here, and I've certainly been blessed to work with some of the guys that are around here, and women in particular, who are fantastic surgeons. So ultimately the goals of the surgery, there's a couple of things. We like to restore the normal anatomy. We want to get back to it as normal looking as we can. We want to hitch up everything, have it back to where it began. We want to reduce that bulge, but more importantly, improve quality of life. The success or failure of someone else's operation shouldn't be a deciding factor with you. We do know some patients might come in and say, well, my sister had this operation, or my friend did this operation and didn't really work for her. It really depends on the degree of prolapse that you're having, because the operation needs to be tailored for your needs. And both you and your doctor, over not just one visit but several visits, will figure out what is the best treatment for you. So, PFDs or pelvic floor, they're not a normal part of aging, and we can treat them successfully, from a range of just conservative treatments, medical management, or even surgery, but ultimately engaging between you and your physician and coming up with something that works. If you go online, you can look about how to do a Kegel exercise. It's very simple. One way we describe it, again, not to be crude, is like you're trying not to pass gas in a lift, or trying not to pee. It's just squeezing up everything tight and holding that for a few seconds and then repeating it a few seconds later. So back to your quiz. I don't need to go with the answers. I think you got them all right. So bar the first one, it was 1 in 3. Okay, so put you over very well. And thanks again for being such a great audience.
Thank you, Dr. Forde. And